Hi, good afternoon. My name is Dr. Lisa Tartaglia,
Dr. Sarah Bone.
and we're here today to talk about how does skin play a role in chronic illness. This is a topic that's generated from our serious illness series, and we think it's really important to talk about skin.
Skin is the largest organ of your body, and you may not think skin is an organ, but it is an organ. You have a skin specialist, like you have a heart specialist, a kidney specialist.
Yeah, skin is our first layer of defense. If it's intact, it's the temperature regulator and protects the body from UV light.
Takes a lot of UV damage over the course of a life, especially if a person is a surfer or a lifeguard or maybe a construction worker. If they've got an outdoor occupation, that UV radiation does add up. It's a lifetime total accumulation, but your skin over your time, it does take a battering, and it all adds up.
Right. Sometimes skin gets overlooked and will, as Dr. Bone just said, gets abused with overusage outside without proper SPF. As you can see, the skin plays a very important role in the human body. And that being said, in simpler terms, when you're sick, your skin is going to change and also play a role in your illness.
So physicians will, talk about your skin, ask you questions about your skin, and patients may actually go to the doctor because of a skin issue. And the attention that the skin gets sometimes is a little bit shortchanged.
Usually if skin changes for terminally ill or chronically ill patients, you'll see it first in the color. Sometimes your skin will look gray and sallow in color.
Some people pale. Some people that have maybe more of a tan may look more green, depending on what's happening with them. But your skin color is going to look different than what it usually does.
Yeah. And Dr. Bone, can you tell people what happens and why skin becomes puffy in people with chronic illness?
Well, you can have certain conditions that are going to make your skin look puffy. A lot of people think, well, for sure you're going to get swelling if you've got a heart problem, if your heart isn't squeezing very well, if it's not pushing the blood around your body very well, like you've got congestive heart failure. But also if you've just got poor circulation to your feet. Sometimes the blood gets down there really well. Maybe it's not the arterial blood, but maybe it's the venous system, and the blood doesn't get back up very well. Gravity is working against us our entire life. And it's amazing to me when you think about it, not having swelling in your feet, because most of us only are off our feet for maybe 8, maybe 10 hours. Maybe you're sitting in the couch, your feet are still the lowest part of your body. So really, when you're in bed, is about the only time that gravity isn't pulling that fluid down into your lower legs. And of course, thyroid problems can make you retain fluid and can change the texture and thickness of your skin.
Right.
So those are some common ones that come to mind. Just changing that part of your skin is making it swell.
Yeah, and rashes also play a role. A lot of times people just think, oh, I have a rash, let me put some hydrocortisone on it. But rashes can really tell us a lot about systemic illness, meaning illnesses that are throughout the body, autoimmune diseases, and anything else come to mind for you?
Inflammatory diseases, a lot of those come to mind. Somebody maybe has an inflammatory process, an inflammatory intestinal illness can actually give skin manifestations. And so, I know when I was in primary care, I actually sent a lot of patients to the dermatologist because the patient would come in with a strange rash. And sometimes it's actually a drug reaction that would cause that. And there are some drug reactions that are called fixed drug reactions. So you think, well, it can't be a drug because it's always in this one place. That can be an indicator of an allergic reaction to a drug, to a medication. So you think, oh, it's ringworm, or it's psoriasis, or it's eczema. Those are all different things, and they can all indicate different things, and they're all from rashes. So sometimes we really need that dermatologist to do an evaluation and maybe to do a biopsy. They can look at it under a microscope and they can tell us these are the kinds of cells we see there, and that's what we think is causing this rash.
Right. It's really an important point. And then I didn't really touch on redness. The medical term is erythema, but redness really plays a role. You'll see that as we get less young or as we have chronic conditions, the redness can occur due to poor circulation. And also it can be an infectious process. And sometimes in our line of work, we'll get called and people will think it's an infection
but it's not hot.
It's not hot.
It maybe isn't tender.
Mhm.
You know, so the redness, the erythema, some people have what we call dependent rubor. They just have redness of the lower extremities because they've got that venous insufficiency where the blood gets down there, it kind of pools down there, and it can't get back up. And so if they will elevate, and we say toes above your nose, that you want to get those feet up, but if it's developed over years, then having your toes above your nose is not going to change that dependent rubor. Sometimes your skin actually kind of just changes to be that color, and elevating your feet is not going to relieve it. It's not going to make it less red.
Thinning of the skin occurs usually with aging, and it's because the elastin and collagen levels change in the body, and it really makes the skin look very thin. And I like your analogy for the thinning of the skin. So please tell them.
Yeah, one of the things that happens with your skin is you have the epidermis and the dermis, and they're really kind of sealed tightly against each other. And for somebody who's got an older kitchen and they have, you know, a formica countertop, you know that over time that formica kind of separates that top layer from the wood, and you can kind of press down and you can feel there's a little space there. And that's what happens in our skin. The epidermis and the dermis over time will separate. And when they separate, there's like little capillaries that go between them. And so the skin on top looks thin, and sometimes they'll call it crepey skin in like some women's journal, and they make it tighter, and they do make that top layer tighter, but they don't make them marry once again. And I call it, you know, thin skin versus hide. You know, you get a younger person and they get a laceration, and, you know, sewing up a laceration on a younger person is really easy because the dermis and the epidermis are together, and they're a nice, thick, unified layer. But when you get an older person and that epidermis gets thin and it begins to separate, if they get a skin tear, it's really hard to put those back together, because every time you might try to take a stitch, it's so thin that that suture may just pull through.
And one of separate it further.
And one of the things that happens with that is it's age, and particularly UV radiation makes that separation occur earlier. And UV radiation sun exposure is a lifetime total of radiation exposure, and it makes those layers separate. So when a person gets a bruise, you know, they bump themselves or they're carrying boxes and they get a bruise, it's that purple or red spot, and then it kind of turns green and then yellow and then fades away. That's because of the iron that's in there from your blood, and it oxidizes and it changes color, and your body picks it up and takes it away. But on those purple spots that you see, particularly in older people, those are blood that's been trapped between those two layers. And they're not particularly worrisome. They're unsightly, but they're not particularly worrisome unless you're seeing them in non-sun exposed areas.
As Dr. Bone said, when you have the thinning of the skin, the less elastin, less collagen, it's very easy for your skin to tear because it gets so thin that it can tear. Bruising can occur more easily, again, because of the thinness like she was talking about with the capillaries. And the thinning of the skin can happen with medication. So we see that a lot in our patients that are chronic steroid users. Their skin thins out more frequently and sooner than someone that is not on steroids.
And some medicines may make you bruise more easily. It just as a side effect of the medication, many patients who have a particular heart condition, atrial fibrillation, or that they're at risk because maybe some like carotid artery abnormalities, they'll have them on a blood thinner. Maybe they've had a stroke before.
Yes.
And so those blood thinners are to keep you from having another stroke or to keep you from having a heart attack, to make your blood just a little extra thin. But because your blood doesn't clot as well, it's a little bit more thin, you can bruise that much more easily. And that's a separate process than those solar purpura, which is basically sun purple spots on the skin that are age-related.
Right. When we're talking about skin, we also need to breach the topic, and I know we haven't in past videos, on nutrition, because nutritional changes definitely play a role in skin. For example, patients that have cancer can lose a lot of weight due to the cancer treatments, and they also have progression of their skin breaking down because they're just not getting the proper nutrition. They may be eating well, but the protein is not getting absorbed properly in the liver, and it is a high source of infection if the skin breaks down, as well as a high source of skin tear because it's not getting adequate nutrition.
And like Dr. T said, your skin is a great barrier. It's your best barrier against infection. So if you get a little abrasion, it wasn't the cut that made you get the skin infection, but that cut allowed the seal to be broken in that area, so then bacteria can easily get in. And you put a dressing over or a Band-Aid over it to try to keep that bacteria from getting in there, but it still can. And so it doesn't take much for an older person to get a little break in the skin, and it may be like almost microscopic that they don't even realize they have it. Elbows, knees, maybe on their arms because they're resting on the table, and then they get that redness. The lower extremities, the skin, maybe if they've got peripheral vascular disease, the skin is thin, and it's hard for them maybe to reach their lower legs and feet, so they don't keep them as clean and keep that skin moisturized, and then the dry skin will allow that bacteria to come in. Then they're not getting good circulation, so their blood isn't getting there. So the skin breaks, bacteria gets in, and the blood's not really helping to get rid of that infection. So sometimes when that skin breaks down, you get an infection pretty easily, and your body can't fight it off as well.
Yeah, and then worst case scenario is you get a systemic infection, which means you get an infection that started in your skin that then goes to your bloodstream. And for chronically ill patients, they are very hard to treat, and they can ultimately be fatal.
Yeah, and that's called sepsis. And so one of the key symptoms we look for is shaking chills, what we call rigors. And so if you get a person who maybe has a skin infection, it could be on their arm or leg maybe, or not necessarily inside like with a pneumonia certainly, or a kidney infection, but just a skin infection, and then that bloodstream can't fight off that infection, and then it just gets picked up in the blood, and that bacteria will go through their body, and they can get septic, and it can be lethal.
So just as we discussed, protein creates a healing power. It can be a double-edged sword, because when you don't have proper absorption of the protein, your healing is halted, and then that will cause your infections to worsen because you're not able to process the antibiotics and not able to let the skin come together and mold together to heal.
Maybe you can't process the food that you're getting, the nutrition you're getting. I've had families, come in with a loved one, and the loved one or the patient tells me, yeah, I eat well, and the family confirms they eat everything we give them, but they're not gaining weight, or they're still losing weight. Why is that? Because if I ate what they would, what they eat, I would gain weight, and they're not. So sometimes you can present that nutrition to the body, and as Dr. T said, your liver's not processing it well, you're not making the proteins very well, and that's part of maybe the disease process, maybe a side effect of medications, maybe because of, like a chemo treatment, that, your body is already kind of, while we're trying to attack this malignancy or attack a process, we're kind of attacking the person. And so the skin can really take a hit.
Yeah. Just as nutrition plays a role, mobility plays a role. And I know a lot of you have heard of bed sores. I mean, that's like quite common, especially if you have an institutionalized loved one that's like living in an ALF or even a nursing facility. You're always talking, and Dr. Bone kind of touched on bed sores, but mobility does affect patients in the development of them. And we're just going to discuss a little bit about it to make it a little less taboo and kind of explain the medicine behind it, because sometimes they're not preventable per se. I mean, you can try everything in your power to prevent it by turning patients every 2 hours that are immobile, but there's a lot of other processes that are involved with that.
The turning of a patient every 2 hours, I think Dr. Gutman kind of really was the father of that practice. And there's a really good movie that I would encourage people, if they have time, to look that movie up and to watch it. It's The Best of Men. And it tells the story about a physician and his care for spinal cord victims. Pressure sore is because of pressure, and one of the first things we try to do is make sure their nutrition is good. A lot of times the nutritionist, the dietitian, they're going to do calorie counts, they're going to recommend supplements, they're going to ask for lab work, because they want to see, is there a deficiency in something that we can supplement? And then they're going to recommend offloading. So if the patient has a pressure sore on their behind or on their hip or on their shoulder, are they spending too much time in bed? Are they laying on one side preferentially? And sometimes, because of a problem, maybe a fracture or a cancer process, the patient's like, I'm not laying on that other side. I just can't. So we get special mattresses that we try to use to try to decrease the pressure, because it's the bone pressing against the mattress and the skin kind of gets pinched in there, and so that circulation gets kind of cut off, and that skin slowly gets damaged. Well, I shouldn't say slowly, because sometimes it can happen in as little as 2 hours. And what a lot of people don't realize is that it's not always just because they weren't turned. Many times I know I've been out shopping or I've done things around the house and I've had a really busy day and I just fall in bed asleep and I sleep all night long. And I wake up in the morning, I'm thinking, oh my gosh, I'm flat on one side because I didn't move. But I don't get up out of bed and have a pressure sore. My body may not have moved much, but because of that, pressure, my brain interpreted that from the messages coming to it from the skin and told me, hey, shift a little bit, move a little bit, talked to the blood vessels, told them to open a little bit more, close a little bit more. So even though it wasn't completely rolled over, making me roll over, my body would make me shift just enough that I didn't have that happen, and my skin integrity is good. I'm otherwise healthy. But when you have someone who is very ill, they must be turned on a regular basis. And that needing to be turned and that decline of the skin is a great, sad indicator that this person is very ill, if they can't protect their own skin.
Right. And I think that's the whole point of our video, is to really pay attention to the skin and know if you see things like pressure ulcers or skin changes, just to have an awareness. So you can prepare yourself and your loved one, because sometimes there's nothing you can do to really heal it. It just may be temporary fixes.
And I think some families who are trying to care for a loved one at home that maybe does have just a very short period of time left of life, they kind of beat themselves up a little bit.
Absolutely.
Because the patient develops that pressure sore. And we know that they're doing their best to try to take care of this person. They're trying to keep them clean. They're trying to turn them carefully so they don't get a skin tear. They don't want what we call shearing. We don't want them to, develop a pressure wound. But sometimes if they've only got a few days, or maybe they're down to the last, weeks, but get into the last hours of life, sometimes the rest of the body is failing, and so is the skin organ. So when we know that someone is that close to the end of life, we expect that organ failure, and sometimes that really is what we look for. There's something called a Kennedy wound that we can see when patients are imminent to the end of life.
Right. And we're just trying to normalize you all, like, to have less pressure on yourselves, because it's inevitable for skin changes to happen when you're in the dying process, and do not blame yourself. Before we close, I just wanted to quickly touch on turgor. Like, that's a word we hear oftentimes. It's a medical term, and turgor is used to describe, like, when you can grab your skin. Let's hope that my turgor is good today, because I didn't drink a lot. And basically, it's used to grab your skin and how long it takes for it to recoil back to its original shape, and that determines dehydration. So on a weekend, when I'm drinking less water, my turgor may not be the same as during the week when all I'm drinking is water.
You've been outside, you've been, working in the yard, you've built up a sweat, maybe you've been to the gym, and you get home and you don't replenish those fluids, your skin turgor is not going to be as good. And older people are at significant risk for their turgor to get into trouble, because they're not as good at drinking, and they may have issues like, I don't want to wet myself, so I'm not going to drink as much. The water is cold and it makes me feel cold. The doctor told me I have to limit my fluid intake because of my heart. If I drink too much, then my feet swell too big. So there are a lot of reasons why people don't drink as much water and as much fluid as they should.
Right. And then what you have to look for with a senior is if they have poor skin turgor and then maybe an infectious process, then giving antibiotics will make them worse. They may have more symptoms related from the antibiotics because they're not able to absorb the medication as well and process it for healing. So I just want to talk about how mobility, nutrition, and elasticity play a huge role for us in our line of work as palliative physicians. We always assess the skin when we go out to a patient's home or in the hospital setting. We take a good history of the skin. And that really helps us prognosticate depending on the skin.
If we've got an individual that we think is maybe very close to the end of life, we may see a process called modeling. We may see that skin breakdown like we just discussed. So that skin evaluation, our nurses do a very good skin evaluation and report to us. And then we also like to evaluate the skin and see what those changes are that can also help guide us in the care of the patient.
So it's really important not to overlook the skin. Speak up to your healthcare provider when you notice changes in yourself if you're chronically ill or any of your loved ones. There is, like Dr. Bone was saying, there is protocols that we follow. We do check labs. There are supplements that can be added. And then also know if you've tried all this and it's still not successful, that it's unfortunately part of the dying process.
It may be part of the disease process. And just because we can't offer cure doesn't mean that we don't care or we won't keep trying. We will keep trying.
And we just would like to thank you all for joining in, and we hope you learned a little bit about your skin today.
And if you've got questions or comments, please either email them to us or leave them below. Thanks.
Thank you.